Dr. Win, please unmute your microphone. Can I do that? I cannot. I cannot do it. Yudi, can you unmute Dr. Win, our moderator from muted? น้องหมีคะเราสามารถunmute moderator ดร. Win ได้ไหมคะจากเราเป็นคน control อะเพราะว่าเขาไม่ยอมอะ
I think they sent me a note for unmute, which I did, but I think Dr. Wen's phone is still probably muted. I can introduce myself and use introduction.
I'll ask Nat. Nat, would you like to, at least when we start, would you kind of introduce Dr. Nix, please?
Yes.
All right, so I'll go ahead and start. Can we go live, please?
อาจารย์ครับเขาปิดไมค์เองครับเอง
There was a little note that said you are live to the audience,
So if we, I'm sorry, we're already live. JP?
Great, sure.
Shall I start?
Yes, please. I can introduce and I'll introduce you.
Yes, please.
Okay, just a second. All right. A warm welcome to each one and all for another great session of academic radiology education program. I'm Dr. Panatapura, JP. I'm one of the radiologists at Wake Forest University School of Medicine in Department of Radiology. So for the first time joining us, very brief introduction about what we do. As a global academic radiology education program, this is a nonprofit initiative aimed at providing high-quality radiology education to colleagues worldwide. We started this in 2021, and it's based at the Department of Radiology at Wake Forest University School of Medicine. We offer free online educational resources and live webinars featuring academic radiologists from leading US institutions. This program is designed to build education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars, which starts from January to October, and we cover various radiology subspecialties. And the sessions are well attended, up to 700 participants per live event, and include contribution from esteemed institutes. So our reach extends to radiologists in different countries in Asia, Africa, and Middle East. And our success is driven by the dedication of the committee's members, the moderators, speakers, who work tirelessly without external funding. So in addition to webinars, we also offer projects like Radiology Excellency Program, which focus on mentoring and specializing radiology challenges in various countries. So for today's great session, our moderator is, I'm going to introduce Dr. Nat, and we all know who Dr. Nat is. We don't need any introduction. So over to you, Dr. Nat.
Thank you, JP, and thank you everyone for joining us today. Again, we are the same team as JP, Nandita and Tai. Today we are is an honor to have Dr. Manikam Kumaravel from UT Houston in Texas to speak with us this imaging of sport injuries. So I think we emphasize on the MRI, and Dr. Kumaravel is a very, very experienced radiologist. He was my junior. he was a junior attending when I was a fellow at UT, and we work very closly. And he's very knowledgeable and has extensive experience of being MSK radiologist, director of ACR MSK course, and he actually did his was a radiology resident and MSK radiologist in UK before he came over to the United States and become an MSK radiologist here. And at the moment, time passed by almost 15 years. He became a professor in MSK radiology at UT Houston, as I expected. Dr. Kumaravel, or you can call him next. He preferred that name, please.
Thank you.
Okay,
Thank you,
I'm
Nat,
sorry,
and,
I just come back because I think the problem with the system, but now come back, and thank you very much for introduction about Professor Kumaravel. And yes, so I think now time is your Professor Kumaravel. Sorry about that.
No problem at all. Absolutely. Thank you so much, Sawadi, for those of the guys with different parts of the world. And good morning from the United States. Thank you so much for having me on this program. And then the work you guys are doing is absolutely amazing. I go by Nix, and thanks again for the introduction, Nat, who's a great friend of mine. And it was a pleasure to have her as a fellow as well. She's a wonderful person, in case you haven't met her in person as well. My background, a little bit different, tiny different for atypical for radiologists. I did my orthopedic surgery and rotation in orthopedic surgery in England. And then that's how I ended up doing my FRCS and MRCS. And so I kind of board certified in surgery in general with an interest in orthopedics. So I do have a clinical exposure to orthopedics directly. Did my radiology training in Scotland, and then that's how I ended up with my, and did my musculoskeletal over there as well. I've been across in the United States. This is my 20th year in UT, and we are part of the set up the musculoskeletal program. And my intention is to share my knowledge with you. I would like to focus on both the clinical side as well, but predominantly more on the clinical side of how imaging translates to us as people in radiology or people dealing with imaging as such. That's the whole idea. And I want to do this with a view of I'm a team physician for one of the local teams. It's called the NFL Texans, where Major League Football is very, very big in the United States. And I'm fortunate to be part of them. We had a game last night. And so I run around in the teams. I go to the sidelines. I have an ultrasound machine. I scan them on the field as well as in the locker room. And we do procedures on them inside the locker room as well. And then I certainly look after, we have a large trauma center and in Houston, and Houston has 2 large trauma centers for a population of 8.5 million people. So we get a lot of trauma exposure as well. And I work intricately. I have an appointment inside the orthopedic department as well. And so my idea is to share knowledge with you today. As Nat said, when we first put this together, we're thinking about how it's best to make you guys expert in imaging the sports injuries of the shoulder in about 45 minutes or so. And then because of that, we're focusing heavily more on the MRI portion of it rather than the ultrasound portion of it. And what we're going to do is we're going to go through starting talking with the biceps. We're going to talk a little bit about rotator cuff. We're going to talk about labrum. And then we're going to talk about what the glenoid and the labrum interacts and what happens with it. And more importantly, we are going to try and keep a clinical focus on almost all of these labral-ligamentous complex as well. So these are things that's going to come into your typical practice. This is designed for a general radiologist with an interest in musculoskeletal. And I will show you some flavors of more deeper knowledge in MSK if you ever wanted to do that. I do apologize, I can't see the chat. So my request to Nat and Dr. Nguyen is to say, if you have a comment, just unmute yourself and say something. I'm sorry, for whatever reason, the chat's not visible to me right now. The general outline of what we're going to talk about, we're going to start with some anatomy. We're going to touch upon the pathophysiology of what these injuries are going to do. And we're going to talk about imaging features of what these are and how does this make a difference in the clinical realm. My intention is to translate and say, if I'm the orthopedic surgeon looking at the case, what is it that I'm looking for in our radiology reports? How does it work and what happens with it? That is my primary emphasis of doing this. So we're going to kick off by talking about the biceps complex. So when you think about this bone and glenoid, a ball and socket joint, the primary thing we want to understand is where does the biceps go and what does it do? When you think about the biceps, this is a revision for you guys, which is to say, let me see if I can lay the laser pointer. Here we are. Now let's make you do this. So, so basically you can see that this is your transverse ligament, and that is nothing but the deep condensation of fascia from the subscapularis. And why is that important? The reason why that is important is if there is any injury to the transverse ligament, then what is going to happen is that you are going to notice that there is going to be subluxation of the biceps when you do that. That's the reason why we need to know about the transverse ligament as such. How does it look on MRI? So if you take an axial slice, you can see that there is the medial and lateral lip of the bicipital groove. There's your subscapularis coming into view. And that little dark line here that you see here is going to be your transverse ligament. And you can see how that contains the biceps in the bicipital groove. That's basically what it is. So how do you evaluate this? I mean, as we all know, it's a game of understanding what is normal and not normal. So we have to watch out for the medial lip of the bicipital groove to see if the biceps is still inside the groove as such. And to let you know, we're generally undercallers of subluxation. I mean, like in reality, people want us to call more of them. So have a lower threshold if you can think about it. Moving on to talk quickly about ligaments. One advantage with the musculoskeletal world is if you know the names of the bones, you can start making up ligaments. So in this case, we have the glenoid and the humerus. And so there's going to be a glenohumeral ligaments is what it is. We have the superior, middle, and inferior, and then you can branch it off into anterior and posterior. And if you really think about it, so the main components here is a cartoon demonstrating the shadowing between that. And so here's the superior, middle, and inferior glenohumeral ligaments. These are from primal anatomy. And then you can see the posterior band of the inferior glenohumeral ligament as well. So this acts like a hammock to try and control the humeral head. Of the ligaments, the most important one is going to be the inferior glenohumeral ligament. The reason is because there is no bony support. If you really imagine your shoulder, there is no bony support for the inferior aspect of the shoulder. So the strongest ligaments are going to be the inferior glenohumeral ligaments. How do you go about looking at these ligaments? One of the best ways to look at the shoulder is to take a look at the sagittal. There are a couple of reasons why a sagittal view is very important. Let me tell you why. So if you think about the surgical approach to the shoulder, the surgical approach in most countries now are arthroscopic. And when you have arthroscopic anatomy, when you're looking at it, the shoulder is placed in what's called a beach chair position, which is your arm suspended like that. That is one position. And the other position is getting the patient to lie on the side. So you have a lateral position. So when you do that, the scope itself is actually coming into the joint that way. And there is a posterior portal, which will also be coming down, not to the bone, obviously, but in a different slice where you could, that's how the cameras are placed. So for a surgeon, this is how they're actually looking into the shoulder. So if we can imagine how they are approaching the shoulder, this gives us a better idea of it as well. So on this, you can see there is the superior glenohumeral ligament. And then you identify the middle glenohumeral ligament. To identify the middle glenohumeral ligament, the best way to do that is to go look for the subscapularis, which is this right here. And then anything deep to that will be the middle glenohumeral ligaments. Thankfully, the reconstruction mechanisms for those two ligaments are not so common, so they are less on your list of importance. And here is a more detailed description of the middle glenohumeral ligament looking at that. And there is an anterior band and the posterior band of the inferior glenohumeral ligament. So that gives you an idea about that. When we talk about these, we are forced to talk about this normal variant. And the normal variant is this component, which is you have an absence of the labrum in the superior quadrant of the labrum, and that is where the deficit is. And one of the features that you get from that is this round, thickened appearance. In other words, it's the same deal. Here's your subscapularis. And the middle glenohumeral ligament is immediately deep to it, but it's very thick. And that leads to think about the Buford complex. Why do we care? Why do we care if there is a normal variant? The reason why we care is because you do not want to call a labral tear in this location And if you do, because they'll try and go and fix it, and there is this normal variant. Here's what happens with the labrum. You see that there's a comparative appearance of the labrum, and there is your deficit of your labrum. There is no labrum here. And that's why it's called the Buford complex. And you find an associated thickened middle glenohumeral ligament as well. Let's look at a little bit more detail about where the biceps attaches to the superior glenoid. And here's the biceps. Now you're doing a coronal section through it. And you want to see how the cartilage and the biceps and the labrum interact. And you can see that there is a tight fit between the two right here. So when you look at that on MRI, you want to make sure, what are we dealing with? So if you see this image, the first thing you want to think about is to say, what am I looking at? So I tend to look at the labrum first. So when I see the labrum, I'm trying to see, is there any shape change? I'm trying to say if there's any signal change. If neither of them are there, then I say, okay, the labrum is normal. Then I find this sneaky fluid going in between the two, between the native, the glenoid and the labrum. So if that's the case, this is so smooth and it's in the superior aspect. So this is going to be called the sublabral sulcus. This is normal again. So again, to let us know about normal. One other concept, if you dial your knowledge up a little bit more, is to think about what's called the biceps sling. And I'm going to just give introductions to these complex topics, but just going to keep it brief. So this is a mechanism where the biceps glides on top of the humerus every time you move your arm and do any overhead activity. And what this does and how this is regulated is by these ligaments. You have a combination of the coracohumeral ligament in conjunction with the superior glenohumeral ligament. And that is how these two things are moving in and out. That's basically what it does. How does that look like on a scope? This is what it looks like. You can see, this is you looking down into the shoulder in the anterior portal. And to identify, there's your humeral head right here. And then this is your, the big cord is the long-headed biceps. And then you have this pulley structure, which is this one here. That's basically what it is. So that's your biceps. How does all this look like on an MRI? The first thing you want to identify is to try and find out the subscapularis and then the supraspinatus. And that interval between the two regions, between the superior aspect of the subscapularis and the supraspinatus, is what's called the rotator interval. Why do we care and why do we need to know? As I said, in a lot of overhead activity, that's the region that slides in and out, and a surgeon might want to think about fixing that region, and that's the reason why we talked about it. This is the superior glenohumeral ligament that's going through there. And that is, again, the coracohumeral ligament, that dark band, that tells you, just like in the cartoon before, this is where the biceps is being regulated as it goes in and out of the shoulder. That's what you're looking for, biceps interval. All right, so let's take a look at normal anatomy and see if we can find something. And I'm going to show you very briefly how I read a shoulder. So what I tend to do is, I'm going to let this play. So I'm going to stop it there. Typically, I start with the biceps. So I start with the biceps. There's your biceps. I want to make sure that I don't miss it. It's sitting in the groove, and I want to trace it back and forth. And I want to see where does it go? Does it go to the supraglenoid tubercle and comes back up, stays in the groove? I look at the bicep, the transverse ligament to make sure it's all okay. Then I typically would actually jump with the sagittal, but for the convenience of how we light this up, then what else do I look at an axial? I go and look at the labrum. So I look at the labrum. I want to find out what is the normal labrum in this particular person. So I actually look up and see where these labral structures are. And then I get an idea, this is the normal appearance for this particular patient. So I'm going to use that as a reference. It's a fibrocartilage. For those of you guys who are more used to look at knees, it's the same cartilage. We're looking at the same fibrocartilage. So you look at that and you make sure that the contour and abnormality of that labrum is looking good. I'm looking for labrum to hug the bone, which is what it's doing on both sides. And I'm watching it as it goes across top and bottom, and I don't see a tear. And then I jump over to the coronal images. Here's our coronal images. And when you look at coronal images, the first thing you want to do is, again, check the biceps out. See what the biceps is doing. Here's the biceps going across, being taut. It's going to the supraglenoid tubercle region. It's attaching right there. And then it also tells you what's happening to the biceps labral complex. So looking at that, because majority of the patients who are going to present to you with overhead activity and pain are going to be patients who are going to have problems in the superior labrum as such. That's what they're going to go with. All right, so I go look at that and trying to find out the contour and trying to see if there's any change in contour. If there's any intrinsic signal abnormality inside, that is what I'm looking for. And that's what I do with that. Other things you can do, which is very naturally to do, most people do this, is to look at the rotator cuff on the coronal images. And that's fine. It's not a problem. So you always want to go all the way anterior. That's your anterior-most landmark because that tells you where the biceps is coming in. Then I look at the footprint of the rotator cuff. I look at the footprint of the supraspinatus. Then I follow the footprint of the supraspinatus and the infraspinatus as it goes backwards. Things that you want to know about when you look at the tendon is to look at the articular surface. Then you want to look at the bursal surface. Remember, there is still some magic angle artifact with these kind of imaging because it's as you understand, as you remember, magic angle is a spurious high signal that comes into any structure that goes 55 degrees to the axis of the magnet. And so we need to overcome that. And what do we need to do to overcome that? We typically use a heavily T2-weighted study. In our situation, we use the sagittal, and I'll show that to you in a second. So I look at the rotator cuff and I follow it back and forth all the way across. That's what I do. The other things I look at when I do this is also to look at the axillary pouch, look for the ligamentous attachment over here, and then also the subacromial space and the acromion as well. That's another thing you want to take a look at. And then I'm probably not going to show you, I'm going to show you T1 as well, but you want to look at the neurovascular bundle, both at the neck of the humerus as well as the neck of the glenoid as well. Those are things that you want to do. All right, so if you move to the next one here, here's my sagittal. This is one of the most useful sequences in the shoulder and also helps you understand it much easier. So here's a spine of the scapula. So this is supraspinatus, infraspinatus, teres minor, and subscapularis. And what we're watching for is, let's watch the supraspinatus, see the anterior-most margin of the supraspinatus, see how it comes and attaches all the way to the footplate of the humeral head. And if you have time, next time, when you see a skeleton, put your finger onto the humeral head and you'll see there's a nice flat groove onto which this comes and attaches. And remember, that's why I told you a surgeon puts a portal this way and portal that way. And that's exactly how they're going to fix it right there into the rotator cuff region as well. So that's a reason for looking at it that way. So then I look at the infraspinatus, follow that, and that forms the conjoined tendon in the middle. And they all come to the front and they get attached there. You can also see the subscapularis coming and attaching to the lesser tuberosity. And then you can also see the teres minor. There's hardly anything that goes in the teres minor except for neurological stuff. There's no real fixation of the teres minor and things like that. So just to watch out for. You get a great shot of the biceps as well, just to see what happens to it as it goes through. That's another thing we can look at in this region. And then the acromiosseous outlet. What does that mean? It just means that the space between the humeral head and the acromion gives you that real tunnel into which the rotator cuff comes out. And that's something you can watch out for. And the last thing is ligamentous attachment across here is what I do. On the T1, I look at the marrow of the bone because it gives you a nice appearance of what's happening to the marrow. As such, we're looking at that. This is an arthrogram. And then you can also look at the ligamentous attachment, which is a coracoacromial ligament across here. And you can see what happens to the acromioclavicular ligaments as well. That's another thing that gives you a good idea about. And then in this image, I also look out for the bulk of the muscle, trying to see if I can think about neurological things that happen with it. The last thing is, again, to look at the neurovascular bundles. You can see that the neck of the glenoid, you can see the neurovascular bundle just skirting around here, as well as the humeral head. Here is your neurovascular bundle. Here's your neurovascular bundle. All right, so that gives you a basic idea about how to look at MRIs. Have a pattern, biceps, jump across to do the labrum, superior labrum, inferior labrum, anterior, posterior labrum, look for labral, normal labral structures. Rotator cuff, follow the supraspinatus, infraspinatus, subscapularis, and teres minor. Look at the neurovascular bundle structures and the ligaments as such. All right, let's have a look at this case, a couple of cases. Here's a patient who came into the fall, typical injury. You can see there's a great tuberosity fracture. And it's like, yeah, there's a great tuberosity fracture. I agree, there's a floating fragment inside the bone. It goes across, involves the great tuberosity as such. And here's your axial as well. So let me just minimize this. And then so you can see that there is your fracture extending to the great tuberosity as such. So this patient had difficulty in reducing for a while. So I'm going to run you this MRI. So they said, okay, you know what? Why are we not able to completely reduce the shoulder and see what happens? Let's take a very quick look at this and see what do you think about the biceps tendon as it goes through. We talked about the biceps and the axial, so ignore the rest of it. There's a lot of action going on. So I'm going to let it run for one more time. Have a look at the biceps. And here's your biceps. See what happens to the biceps? Right there. So the biceps, unfortunately, is getting, let me just stop that. And you can see that the biceps is getting trapped in between the two fracture fragments. And why is that important? The reason it's important is because it's what traps the tendon inside, preventing it from going further. Imagine that's going to alter the function of the biceps. It is also going to prevent the reduction of this long term. That's the reason why we need to know about that. So here's what it looks like on a coronal image. You can see that right there. you can see the biceps going across all the way. So watch out for these situations where you have difficulty in reducing shoulders, and this is a trapped biceps tendon. Another patient who's a basketball player with a long history of about 4 months history of pain. And Tilly, I'm going to let you think about it for a second, pause on that image, see what you guys think, and then you can see that there is a little split in that biceps as such. So what about bifid biceps? So this is a long out of biceps, as you know, and the bifid biceps is the incidence is very low. It's 0.05%. So your chance of seeing something like this is going to be very low. So what do we need to say when we see these things? So the idea is to think about, let's imagine this to be, oh, God forbid, it's your own shoulder and you have one of these injuries, what would you have? They're going to present with anterior pain. Our idea is to say, how far is the tear? What is the extent, craniocaudal extent of the tear? Does it go into the biceps anchor? And in older patients, it doesn't matter because you can do what's called biceps tenodesis, which is cutting the edge of the biceps so that it actually retracts and runs back. But in younger patients, you might think about sewing this up and reducing it. So that will be to say that the treatment of that. So for that purpose, you need to know what the quality of the tendon is. And you want to say proximal distal tear, and you also want to think about, is it subluxing anywhere? Is it going anywhere? Because that will mean that there's going to be associated repair of the subscapularis as well. The commonest location for the biceps to be re-anchored in a patient is going to be in the subpectoral region around here in the humerus is where they would go. So remember that. So you're looking at that region as well, so they can actually put it back in there. What about this one here? 45-year-old, slightly older patient now with the anterior bicipital pain. So take a look at this, and you have a look at this and see what you think. And what could be the reason? And you're looking at the biceps again, and you're focusing on the biceps in this particular image, and you can start seeing that there is this irregular, shredded appearance of the sheath as such. You see that there is going to be irregularity, and then there is more irregularity across there. The finite structure of the biceps is not clearly seen, and that's what's happening here. So this is a degenerative tear of the biceps tendon. You have only a portion of it still remaining, and let's see what it looks like. And there is your associated tear of your subscapularis. Remember, every time you have a subscapularis tear, means that the biceps is also compromised because the biceps regulating ligament, which is the transverse ligament, is also torn at the same time. How does it look like on a sagittal? Here, what we are seeing, there's your biceps sling that we talked about right there. See, there's some tear in it, and there's your biceps that goes into it as well. All right, so that's an associated tear. That's a degenerative tear of the biceps. Let's move on and talk about another case. Here's a 65-year-old patient. And here's what happens. So anterior bicipital pain, and they came in and got an MRI. And what you're seeing here is the transverse ligament being thickened. You can see there's irregular thickening of the transverse ligament. There's a subscapularis that is also torn along with it. And you can see that this is going to be a biceps that's going to leak out. And here's a classic situation, what happens. So see this? And this is going to be your medial bicipital groove. So if I can draw on that. So this will be this is your medial, this is your medial bicipital groove right there. And you can see that the biceps is already subluxing into the joint as such. And that's the reason why you're seeing this as a biceps subluxation associated with a superior glenohumeral ligament tear and also a biceps rotator interval injury right there across here. All right, and there's your subscapularis tear. And there is multiple ways of classifying the subscapularis. The LaForce classification is what we use, but we're not going to go into that, just to let you know what different things are. Let's stay with the biceps and take a look at another one. Here's a 42-year-old patient with sudden onset pain, and they say, hey, no, I can't lift things. And suddenly this is what happened. So you look at this, and there is this little sheath of something like, this is an acute injury, remember? So this is this is somebody who came out from the gym and said, I felt something pop. And you're seeing this, and then you go up and you see an empty groove. There's no biceps tendon sheath inside it. And then you go higher up, and again, same thing. There's an associated subscapularis tear and the capsular tear that's going on. And here is a little stump of a biceps. So this is a proximal bicipital avulsion, and that just tore all the way coming across. No, it's actually, take it back. It's not a complete avulsion, but a full thickness tear. And when you look at that, what are we supposed to say? Again, you're looking for, if there's any continuity, is there anything going top and bottom? If there isn't one, then is there a stump of biceps left? And if so, how big is the stump? And if you can give an idea about the size of the stump, that is again useful, because there are some situations in younger patients where they can be still repaired, and you can reattach depending on how big the stump is going to be. One of the associated findings is you can see that the irregularity in the inferior capsule that leads to an inferior capsular tear, and that's what he's seeing all the way across here when you think about this as a capsular tear as such. Going at a little bit more higher velocity, here's a 28-year-old who was in a car crash. As soon as you see this, you realize there's going to be lots of things and lots of ligament tears. I'm going to try and focus your attention to the biceps. That is an empty groove. Let me take that back. That looks irregular, but I really don't see it, which means now I need to start thinking about where is this going in a young patient. And I notice this little extra structure. And if you keep your eyes on it, you will see that's actually medial to the biceps groove. And also in the same image, you're looking at the things in the back. And that tells you this is a point where the whole shoulder was dislocated at some point because the humeral head had impacted the posterior aspect of the glenoid and knocked it over. And that's what you're looking at, right? You can see this associated tear of the biceps. It's now catching in between the subscapular wrist and the humeral head as it goes down. And there is your tear in the subscapular wrist. That's the orange arrow showing you a tear in the subscapular wrist. There's your biceps getting in between. There is a ligament injury at the back of the shoulder right here. That's the reason for showing you this one here. And then you can see that the biceps is actually trapped between the humeral head and the glenoid. And that tells you there's an entrapped biceps as well. What about this one here? Sudden loss of power. Let's see if this will run. And you can see here is your axial images as it goes through. Excuse me. Sorry, give me 1 second. I just need to get my pen back. And here we are. All right. And here's what we're looking at. So keep your eye on the biceps. And I'm going to pause this and show this to you. So here's your biceps tendon. A lot of high signal across there as it comes down, and keep your eye on it as it crosses over into the elbow crease. And there it goes, boom, all the way disappearing on you. And the normal site of attachment, as all of us know, is the radial tuberosity, is where the biceps will come and attach. And that's what the biceps should be attaching. So this is a high-grade tear of the biceps distal attachment. And what are the things that we're supposed to see in this, and what are we supposed to tell them? It's again the same component of how far is it, where is the retraction, and you can use your sagittal images to talk about retraction as well. So here's your retracted full thickness tear of your biceps. So these situations clinically are fairly straightforward. In other words, you can do what's called the hook test, which is put a finger around your biceps and ping on it. And then you can see that you can catch your biceps as it does that. And this is a clinically, most of the times when you have a high-grade tear such as this, most of the times it's fairly straightforward. So why do they do the MRI, and what do they want to know from us? They want to know how far is it retracted, what is happening to it. And the reason why they want to know how far is it retracted is because you want to make an incision right next to it and grab the tendon, and that's the reason why you want it. And one reminder to everybody, I'm sure you know this, every time you give a landmark in the human body, particularly in the musculoskeletal side, you want to think about how would this be visible to a clinical guy. In other words, if you tell them the radial tuberosity, that is not a structure you can actually palpate. So that gives you an idea how far it's gone, but it's not a structure you can palpate. So I typically use the things like elbow crease, medial epicondyle, lateral epicondyle to tell them that the retracted component is at the level, in this case, of the elbow crease. The elbow crease is that little line that you see on your skin where the fold is. And you also want to give them how far. Yes, I do give them a distance about how far it's retracted, but I want to use a clinical landmark to say where is it retracted and how far is it retracted. That's what I tell them. The other thing I tell them is also to tell them about the quality of the tendon, if there's anything at all that's going on. And the most important thing, if you can find one, is please look at the x-rays all the time you see one of these things, and also try to find if there is a bony fragment that can be put back together. So that's a distal rupture. Every time you think about the biceps, think about the subscapular, think about associated things that can happen across to it, and then CT for bony anatomy. All right, let's move on and talk about a little bit more. Here's a rotated cuff in a squash player. So look at this, and this is gap coming across. Every time you see one of these, you really want to think about what surface is involved. Is it all the way through? Is it only involving the articular surface? Is it involving the bursal surface? And if so, how much of retraction is there? So this is a high-grade partial thickness tear. It's a peripheral tear. It's a rim rent tear that you have across there. And that's a supraspinatus that's being involved. And then you also see this tendinosis that's going into the underlying tendon in the myotendinous structure. That is what the red arrow is pointing to. So when you think about partial thickness tear, you are looking at the most vulnerable portion where these things can happen. It's the lateral 1.5 centimeters. You want to see how far is it retracted. And you really want to tell them, is it actually an articular surface or the bursal surface? The primary reason for that, let's go back a quick second for a second here. So the reason is because when you place scopes, there are two places that you can place a scope. One is to go to the intra-articular component here, which will be the articular surface of the bursa that you can see. And the other thing is going to be in the bursal surface. You have to put a scope into the bursal surface to see the bursal side. So if you describe only a bursal sided tear, they have to put a scope in the bursa to actually see it. So remember that. And that's the reason why it becomes very relevant to say, which side is it torn? And then you talk about this component here, the interstitial component. Remember that is going to be, you have to be careful with this. The primary reason is because when you use the interstitial portion, they cannot see it. They have to dig into it to actually see it. So you cannot see that. And that'll be one of the things. And so this is talking about the bursal surface of the tear. Where is it torn and how far is it retracted? Let's move on to talk about another case. And here's what it is. This is a very straightforward component of it. You can see there's an arthrogram done, a full thickness tear, fluid extending all the way across into it. When you watch the fluid, when I'm looking at these, I'm looking at, is the fluid going into the subacromial space? The first thing you realize is anytime you do an arthrogram and the fluid tracks across into the subacromial space, then there is a full thickness tear of some kind, and that's the reason why you got into it. In this case, it's even more important because it goes into the into the acromioclavicular joint like a geyser phenomenon, which means that it's also communicating. And that's useful information for them to know when they're looking at these. That's a full thickness supraspinatus tear. You really want to spend time talking about how far is it? Is it anterior, posterior? What is it, articular to bursal or bursal to articular? I mean, like, what portion is it involved? Think about the lateral critical zone and think about retraction of the tear that goes along with it. I want to show you one more image across here. This is important. The reason is because what we're looking at here is to see what happens with the quality of the tendon. So pay attention to this. It gives you an idea about the delamination portion. So what do we mean by that? What we're trying to say is that tendons are in layers, and you can see contrast just dive into this portion here. It's imbibing into the tendon material, and that's the reason why we have this, and that is going to be what a delaminating tendon is going to be. Let's look at another one. I'm going to let this run for a second. Have a look at this. Think about what the tendons are doing. Focus on the supraspinatus. So let's make it easier. Let's run this again. Focus on the supraspinatus and see what you think it does. How far is it torn? What is happening to the infraspinatus? All right. So let me pause that. And here we are looking at this. So here's your foot plate attachment. I see a bald area, which means that's a full thickness tear that's happening there. And then as I go through, I get the rest of the tendon. So it's only the anterior portion of the tendon that's involved. And then I see the rest of it where you can see, again, irregularity. There's a lot of tendinosis of the infraspinatus that goes through. All right, how does it look like on a sagittal? As I said, this is the most valuable sequence that we can use. So let's take a look at that. So go back all the way to the spine. Here's the spine of the scapula, supraspinatus, infraspinatus. You're going to watch them come over and grab the humerus as it goes through, and that's what you're looking at. And so look at how the tendon comes in, and there is your area where there is tear going across all the way. So there is a full thickness tear. And then if you look at the infraspinatus, there is your tendinosis in the infraspinatus as you walk through the footplate of the infraspinatus as such. Hopefully that's useful. So what we tend to say in our reports is to say, what is the anterior posterior extent of the tear? How far is it retracted? So give them two dimensions, AP dimension, retracted, medial lateral dimension as well, to talk about how the tendons are. Here's another one who's a slightly older patient, but now playing a weekend of basketball. Have a look at this and see what you think. All right, so let's run that one more time. See what you think about the supraspinatus and the infraspinatus. So these are ones that's going to be going across all the way. So there is your the supra and infraspinatus. Let's pause that and take a look at it again. Sorry about that. Here we are. And then come all the way anterior. The coracoid process tells you the anteriormost landmark. Look at the footplate attachment of what's happening. You get some irregularity. You get some delamination that's going through that. And the same deal again on this side as well. So you can see here we are looking at the tendon, and here's your gap in the tendon. And that's your tear in the tendon as such. So this is a partial thickness tear that's happening, and you can see fluid tracking across into the subacromial bursa as well. And that's bursal fluid that's there. So another one, let's look at this case again. And let me pause that in the interest of time and show you. There is your tear in the peripheral aspect, retracted. And then this is the tear that's happening right here. And as you page through it, you can see what's happening to the rest of the tendon. That's the posteriormost landmark. And they're all getting attached and staying intact to that point. This is the infraspinatus coming from the back, and you can see all of that. And then let's confirm that with our sagittal projection. And here's what we're seeing. There's a full thickness tear in the anterior portion. The rest of the tendon is actually intact right there. And then here you can see the infraspinatus, the tendinosis there. This is a full thickness tear, the anteriormost fibers. The other one is a slightly partial thickness tear. So here's what you're looking at. And this gives you a confirmation of where the tears are going to be. All right, what about this one here? It's a slightly more bigger injury again. So this time we're looking at what's happening with the patient unable to move, but just edema confined to just one muscle. So let me show that again. So let me pause that. And here's what you're looking at. So look at where the muscle is and look at where it's going. So behind the spine, infraspinatus, and here's what that looks like. So if you look at the coronal, here's what you're looking at. So you're looking at the infraspinatus, all the muscle edema extending to the entire component. So this is again a partial thickness injury of the infraspinatus. And again, sagittal gives it away. It makes it much easier. So here we are. Go across here. You can see the infraspinatus. Let's follow that as it goes out. And you can see this is a muscle and myotendinous injury, but no full thickness tear. This is a partial thickness injury. So this would just mean that they're just going to rest this patient and get this, get them to heal up rather than do anything interventional. The T1 gives you the bulk, which means to say that this is a recent fall, but the 70-year-old has not been using the infraspinatus as much, and that's the reason why you get some atrophy as well. You see that, and also use this to tell you if there's a fracture and things like that. So that's another one that you want to correlate with as well. Now this one here, again, is going to be, let's take a look at this. So you can see that the biceps is subluxing. Let me pause this. I'll walk you through this. So let's start with the biceps. And here's your biceps. We go across. And you see that it's subluxing next to the bicep, the medial lip of the biceps. So that's your biceps being completely injured. We see that the biceps is now subluxing tendinotic appearance. The next thing we know is there's definitely tear of the subscapularis because that's the reason why the biceps came out in the first place. That's how we know that happened. All right, and then I'm going to run this for you and take a look at the biceps again. And we said that before. Here's your biceps. That's your biceps going in. Then I look at the superior labrum. That looks irregular all the way. We know that the subscapular is already injured. And then I look at the articular surface of the supra and infraspinatus, and there is a little irregularity. So just watch this irregularity. And then I'm going to try and say, hey, what does that do? Where does it happen? And then the ligaments are okay. So we're going to do something called the Aber position. The Aber position is one. Let me just first run the sagittal for you because we can confirm that. So watch the supra and infraspinatus. It comes around. Here's your supraspinatus. Here's your infraspinatus, subscapularis. And as we watch that, we can see there is some irregularity on the articular surface of these tendons sitting right here. So, and then not in all cases, but in overhead athletes, we do these kind of Aber position. As you can remember, Aber position is like that with your arm extended and your shoulder backwards. And the advantage of that is it stretches out your anterior capsule. And this is something, it's abduction, external rotation view is what you're seeing. It's almost like the humerus is being suspended across from that. The reason why we do this is to, as I said, is to look at the anterior capsule, and we also want to look at the undersurface of the biceps of the rotator cuff. So let me pause that and show you how do you read these. The easiest way to read them is to understand where is anterior and posterior. So this tendon here is biceps. So that is your anterior-most landmark. So from that, you're going to span through the rotator cuff as you go through that. So you're going to watch this. And there is your undersurface, and that's exactly where the irregularity, sorry, my bar is actually blocking some of this, but that is exactly where you have the undersurface tear as well. So this is a partial thickness undersurface tear of the rotator cuff at that location. All right, so that's basically what it is. One last thing about repair is to show you how repairs look like. So when you look at this, there's going to be artifact, and this is the classic reduction. They do what's called a double row repair, pull the tendon down, put an anchor here, put an anchor here, put an anchor here. So what are we looking for? We're looking to try and see big retractions, all right? Very small tears, we're not going to be very good. But the reason is because the artifact is going to dominate. But big retracted tears, you can find out, use this image, and use some heavily T2-weighted image, and even a non-fat saturated image to tell you, there's your anchor, there is the integrity of the tendon. So they're basically trying to find out from us, is the integrity still there? Do I need to go and operate? And that's basically what they're looking at. Let's look at the sagittal. And you can see the same thing. So go to the spine of the scapula, come back up all the way. And you can see that there's your rotator cuff, and then comes and attaches to the humeral head. So keep it simple, have a look at it, and here's your non-fat sat version of it. You can see that's where the anchor goes in. We are typically using multi-point Dixon to achieve this with the T2 weighting. And so that's how it's easy to get the fat and with and without. So we're trying to see that as well. And that's what you're using in your magnets as well. Let's run through and talk about the labrum. It's a fibrocartilaginous structure, makes it deeper. That's what it is. The biggest thing to know about it, normal variants live in the anterior superior quadrant. That's what it is. And anterior superior quadrant, this is just to show both sides of it. Crookite process gives you the anterior landmark. So this is the anterior superior on opposite side. And we are using a clock face of saying 3 o'clock anterior to be the main thing. So this gives you an extent of the tear of where it happens. And then leads on to this topic called the slap tear, which is a superior labral anteroposterior lesion. There are multiple types of it. Don't worry about it. Let's see what we need to know about the slap tear. Slap type 1 is almost degenerative. So it happens in everybody who's more than 40, 45, you get a little irregular appearance of it. Slap type 2 is probably the most important thing that we need to know in the entire component of slap. So what we're looking for is we're looking at the integrity of the labrum, right? And on that, you can see a little high signal that's going in between. That tells you that you're dealing with something like a line going into it. So that's abnormal. That's what we know. And that tells you you're dealing with a slap tear. Why is this not a sulcus? The reason why it's not a sulcus is, see this little tissue there? That tells you that's still labrum. And you look at that, you can still see labrum. So you are seeing a signal going into the labrum, and that's why this is a slap type 2. This is the commonest type of slap injuries we're going to run into. So that's what you're looking at here. And then you have other types like this one here, you get a little flap. And then this is another one where there's fragmentation. The most important component of this is to see, does it extend into a biceps? And this is where the other component, and this tells you that there's pain in this patient because of extension to the biceps. There are other types. We do not report on types of slap at all. At least I don't, and we don't do it in our center. There's just multiple varieties to show you that it goes through ligaments. It can go through different components of it. And do we care? Not at all. You don't have to do the numbers. Just remember that. You don't have to do the numbers. Just describe where the tear is. Is it going into a quadrant? Is it going anterior, posterior? How far does it extend on a clock face? Always use the quadrants. The quadrants are anterior, superior quadrant, inferior quadrant. That's basically what you're talking about. And how does all this look like if you wanted to take a look? And this is a looking on the scope, and here's your biceps tendon. You're looking at the labrum on either side. And that's how you put a hook down there and pull on it to try and see if it's actually intact. And then a torn labrum will look like this. It looks irregular all the way. And this is what it looks like if you wanted to repair it. So you're looking down the anterior portion, and you're looking at the labrum that's torn. They're getting an anchor across here. And their intention, I'm going to speed this up a little bit. And this is your humeral head on the side, and that's glenoid. You're looking down through the anterior portal. This is a 30-degree scope through which you can see that. And then you're putting an anchor across here. You're going to try and put the anchor, see how the anchor comes in. And they're going to knock it in. And then basically what you're trying to do is to, after you place each anchor right there, you're going to try and beef it up together to build the labrum around it. There are multiple types of anchors now. This is just one of them. And then you can see how that actually is being repaired as such. All right, hopefully that gives you an idea. And then at the end of it, you again pull on it. There you go. You pull on it to make sure that the integrity is preserved. And that's how it is done. All right. So what else do we need to look for? I mean, so when you look at injuries of the labrum, you always want to focus on what's happening right next to it. That's very important. Just to give you an orientation again, this is your labrum. So here's your normal labrum. This is what the normal labrum of this patient looks like. But then there is this irregularity anteriorly. So see, what do you think about this? Focus on that for a second. See what happens with that. There's irregular appearance. Go back and you can actually see there is your labral tear. And more importantly, there is also some periosteal stripping that happens along with it. And there is your cartilaginous component too. There's a little cartilaginous component that's actually being involved in that region as well. So watch out for that. And this would become what will be a soft tissue-based lesion. And we are dealing with, as you guys have rightly guessed, a soft tissue back cartilage. So you're looking at the labrum, you're looking at the periosteum, and you're looking at the adjacent abnormality. Let's look at another one. Here in this case, you can see there's obviously abnormality anteriorly. You can see all of that irregular appearance here. And then when you look at that, you're thinking about what's happening to the bone underneath, what's happening to the periosteum, what's happening to the labrum, and what's happening to the cartilage. And that's what you're looking at. There are clues in these images to tell you whether there was violence in all directions. This particular arrow here, I mean, this one here, the posterior, this landmark here, this is your Again, we know that's your ligament at the back, so that's a posterior glenohumeral ligament. That's what's being torn at that point, and that's basically what you're looking at right there. That gives you an idea about the assessment of it. This gives you an assessment of how much of the bone is involved. That's what it is, a large area of bony injury that's happening along with it. So this is a massive bony backyard injury that you're looking at. The next thing you do, you look at your radiograph to try and find out how much of bone is there involved. So you see the little bony flake, and that's, you have to do a CT to evaluate that. And when you do this, you're trying to find out what portion of the glenoid is involved and where does the fragmentation come across. So how do we measure this surface? So I'm going to show you 3D. This is what we do. We draw a circle around the glenoid. Then we try and draw a portion around it and try and tell them what percentage is involved. The reason why this is important is because when it goes beyond 20 to 25%, then that makes it unstable. So the humerus is not going to stay there. It's going to start subluxing, and that's the time you need to fix these. So 20 to 25% articular surface involvement is what happens, and that's the reason why. I know we don't have time for this, but I just want to introduce the concept. Bipolar lesions are when the humerus and the glenoid surface needs to be looked at. And here's a bony fragment. So we're talking about, I'm not going to go into calculations, but I just want to introduce the concept to say, this is a time where the glenoid and its interaction with the humerus is important. That gives you a glenoid tract, and this is what happens. So we are trying to think about, if I have a glenoid and I have a break in the glenoid, is my humeral head going to stay on it, or is it going to fall off it? Because there is also a Hill-Sachs lesion that happens along with it. That is an on-track lesion. This is a less severe injury, and this will match. And that's this Hill-Sachs defect is smaller, very small defect. That's the reason the humerus head is still going. If you have a large Hill-Sachs deformity, then the glenoid breaks in the front, the glenoid tract becomes small, and this is what's called an off-track lesion, because this will now become engaging. What does this mean? It means that every time I rotate my arm out, it's going to get caught in it, and that's the reason why this becomes an engaging glenoid abnormality. So hopefully that gives you an idea about what we think about. We don't have time to run into the mechanical measurements, but all you're trying to say is when you have a shoulder dislocation, you're thinking about the glenoid and you're thinking about the humeral head at the same time. That's why it's called a bipolar lesion, and that's the whole idea of showing you this. What do? They do one of these, which is reduce it, and fix it is what they're trying to do with these things. All right, and that's called a latter procedure. All right, in the interest of time, I'm going to jump across to the slides and see if I can, posterior instability, just to show you a quick image. I'm going to run through these cases a bit because in the interest of time, this is a fracture across in the back end of the glenoid. So it tells you it's a reverse bony backyard injury. And that's what that one is. All right, and football is the game that I go into. This is one of our teams, an old picture. You can see a lot of violence when people fall on each other. This is what happens with them. You get an injury right across here. As I said, anytime you see one of these, think about the cartilage, think about the labrum, and think about the periosteum that's there. So this is the cartilaginous injury that happens along with it. And remember, when you zoom up and take a look, you're looking for cartilage that is fragmenting away. So focus on the labrum, focus on the adjacent cartilage, focus on the adjacent periosteum and the bone. This is going to be called a glad lesion, where there is a glenoid, labrum, and articular surface involvement across onto it. And that is what that looks like. And when you look at this is what it looks like. You see fragments coming off it, and then you do a fixation of debrising it. So basically all they do is they go and smoothen the margins and they put the thing back together. The last one I want to show is, again, a glenohumeral ligament injury. You see this little high signal across here. As you pan through it, you can start seeing the signal abnormality. And when you look at it on the sagittal, you can see all of that inferior glenohumeral ligament signal abnormality. And what you're dealing with is a humeral avulsion of a glenohumeral ligament as such. All right, and this is what it looks like in fixation. Remember this: you have this running through. I'm going to show you. So you're looking down into the portal. You're grabbing the two layers of it to put it together, and that's what they're going to tie together. This is what synovitis looks like. This is what cartilage fraying looks like, and you can see how they're going to pull that back together. And that's your inferior band of your glenohumeral ligament that's going to jump across that. All right. And so in summary, what we did there was just to talk about the basic anatomy, have a structure, think about how you're going to go through this. Think about the biceps first, because I tend to forget it. That's the reason why. You want to talk about the quality of the tendon. You want to see if it's subluxed, if it's actually torn all the way, where is it retracted, it's going all the way to the biceps anchor. You really want to think about involvement of the superior glenohumeral ligament and associated ligament injury. And typically there's more injuries than what you see, and that's one of the things to think about. When you think about the labrum, you want to think about, first you want to identify a normal labrum. And that's going to look like exactly like your meniscal cartilage. And so go look at that and then think about all the normal variants. The normal variants are all going to be in the anterior superior quadrant. That is the place we have to be careful when you talk about labral tear. Then you talk about displacement, if it's actually further out displaced or is not. You want to think about the adjacent periosteum and then the cartilage next to it, and then think about the adjacent bone. If you have bony injury, you want to think about what percentage of the articular surface is involved. Is it 20, 25%? If so, then they're going to actually fix it. Otherwise, they're not going to fix it. That's the reason why I'm going to think about it. And think about the cartilaginous component as well. With glenohumeral ligaments, focus on the inferior glenohumeral ligament because that is the one that's for main stability. That's the one that's going to edema and tears through that. So watch out for that. So here are some references for you in case you wanted to know a little bit more. And I'm so grateful to all of you guys. Thank you so much for the opportunity to present to you. Thank you so much. Thanks so.
Thank you very much for very comprehensive lecture. And I think people gain a lot of knowledge after following this lecture. And it's very important and also very special when the orthopedic surgeon doing MRI, so you know what exactly you need to know, and then that's the very useful experience sharing for us. And I'm sure there's some question from the audience. So I think the one question from the audience is the complete tear and full thickness tear the same?
Excellent question, sir. Thank you so much again. And so thanks for the question. So what I tend to use is I try to talk about the tendon in its anteroposterior and mediolateral dimensions. So the reason why I want to mention that is to say, I'm going to draw here on my slide. So just to tell you, so if I'm going to be looking at a tendon that's going like this, right? And then I'm going to use this, and that's a block, and let's say that's supraspinatus. And then what I'm going to do is I'm going to think about if there is a tear that involves all of this region, and then let's say this is anterior, and this is posterior. And then if there is a tear that's going through all of this, I call that a full thickness tear of the anterior 50% of the tendon, and then say where it's retracted. And if I have a tendon, which is, I'm going to draw the tendon again, and then I say, if there is only a portion of this tendon that's involved, then I would say there is a partial thickness tear involving the anterior 50% with a craniocaudal extent of 40%, 50% to say that's what it is. I would recommend using those terms rather than just using a full thickness tear. And the reason is because the only time I use full thickness, full width tear is if the entire tendon is involved. Then I would say there is a full thickness tear of the entire, full thickness, full width tear of the entire supraspinatus. I hope that helps.
I think a little bit confusing because the question from the audience that the full thickness are similar to complete tear.
Oh, yeah. Yeah. Again, thank you so much again. So, and the reason when it becomes complete is if I draw on this, it's if it becomes all of the tendon, full thickness, complete tear is I would use if all portions of the tendon is involved. Otherwise, I don't use that. And otherwise, as I said, I only divvy it up because how do you call something that's only involving one portion of it, but it's fully torn top to bottom, craniocaudal. So this is cranial and this is caudal, all right? And, you know, and this is anterior and posterior. So that's why it's confusing terminology when you say full thickness tear. So if you're using the term full thickness, please describe what you say, is what I would say. If you are saying, hey, I'm talking about the entire supraspinatus, only a portion of the supraspinatus. Otherwise, I don't use the term full thickness and full. No, I don't.
Thank you very much. I think that you already made clear for the audience. So I think another question. So question from another doctor named Srika. Can we diagnose the surface lesions without arthrography?
Oh, yes. Yes, sir. Thank you. So the question was, can we diagnose Perthes lesions using arthrography? The answer is yes. And the reason is, again, although I didn't show you an example, just in the interest of time and keeping it very general. So my suggestion would be to say, every time you see a labral tear, this is a situation where you have a labral tear that's being displaced along with the periosteal tear. And what I tend to do is to say, where is the tear? Is the periosteum being lifted off? is there a displacement of the labrum? That's typically what I describe. Do I use the term Perthes all the time? No, I don't use it all the time. And the reason I don't do it all the time is because we have a population of dedicated shoulder surgeons who easily understand what I'm telling them if I use Perthes, because that's a group we interact with. And then we have a group of general orthopedic surgeons who don't do shoulders all the time. So I describe these lesions more than you giving them names to it. I hope that's easy.
Yeah, I think everything's quite clear now. So is there any question from the audience? Could you please type on the Q&A box?
And also more than happy to answer them. If you ever want to email me, please do. My last name and Houston will bring you. There's not many of us here.
This is I think it's another question has been typed from Dr. Ken Share from Singapore. So he would like to know the bicep pulley lesion.
What lesion, sir, again?
Bicep pulley. The pulley.
Biceps pulley. Yes, thank you.
Yep.
So biceps pulley lesion is a lesion that we treat in overhead athletes. In the place that I'm in, I play cricket, but I'm in the United States. We don't. It's not very popular, but baseball is super popular here. And in baseball, a biceps pulley lesion is the ones that actually stop these pitchers from actually going full speed. So in those situations, what happens is you have edema in the superior glenohumeral ligament region, and you find that the biceps has also got some tendinosis, and those are situations that we talk about the biceps pulley lesion as such. One little advice is if you ever get a patient coming in for an arthrogram, and your surgeon is saying, hey, I'm worried about a biceps pulley injury, please don't do the arthrogram to the rotator interval. Go down the shoulder, go lower down on the humeral head to do the injection. So if I can, again, sorry about this. Oops, sorry. I was going to draw here. All I was going to say was if you draw the humeral head, such as this, and then a rotator interval approach is where I do the injection around here. And instead of that, I would recommend going down lower in this location here to do the injection, because if you do an injection higher up in the rotator interval region, that is going to obscure what you want to see. And that's the reason why. So biceps pulley injuries are real. They are only treated in specific individuals. Very few shoulder surgeons work on it. The reason is the post-op scarring that happens in the biceps pulley region can be more debilitating than what you actually start off with.
Okay, I think another question from the audience, Dr. Shrika as well. How to identify the demarcate conjoint tendon?
How to identify the conjoint tendon?
Demarcate.
Oh.
Demarcate, yep. Demarcate conjoint tendon.
Oh, okay. I am not completely, I hope I understood the question correct. So if the conjoint tendon conjoint tendon is a place where the posterior fibers of the supraspinatus and the anterior fibers of the infraspinatus come together. So I wish I can go back in my slides easily because without giving everybody a seizure. So it's basically following the tendon as it comes down and attaches to it. So the conjoint tendon lesions are the ones, as far as treatment-wise is concerned, the reason why that becomes interesting is because it's a fascial connection between the two tendons. And to mobilize such a tear when you have the conjoint tendon injury is to work, you have to go further backwards in your mobilization of your tendons to bring them over to get it attached. So every time you use the word conjoint tendon injury, you have to be careful that it involves the region between the two tendons coming together, and that's what the conjoint tendon. I hope I got the question correct, but if that's not it, please type again and I'll answer again.
I think the person who gave the question already satisfied with the answer, and there's no longer have a typing here.
Okay.
Yeah, so as I said, all the images from your presentation, you did the MR with the intra-articular contrast. So is that the standard protocol for everyone, or some particular situation?
Thank you, Dr. Wynn. That's a great question. So do we do arthrograms on all of them? So we have access to multiple 3T machines. So the availability of the high-end MRI is not a problem. But even in that scenario, we do more arthrograms in more centers for two reasons. One is we got into a practice with our surgeons to see how a joint distended appearance looks like. And in those situations, if there is an acute injury, we obviously don't do an arthrogram because there's usually a little bit of blood in the joint and that distends joints for you, so you don't have to do that. In a non-acute injury, when you want to do that, we still instill an arthrogram. In an arthrogram, we use a combination of ropivacaine because it's very cartilage friendly, and we also use tiny amount of gadolinium like everybody does, and then we use the image. And what we're trying to do in that is also to get a pain score before and after the injection with the time. So we are counting on our ropivacaine to give us an idea if the intra-articular pathology was the reason that the patient had symptoms. And so this is another diagnostic component, but that's the reason why we do that. So there are patients, so in most high-end athletes, acute injuries, we don't do any arthrogram because there's already blood. And in subacute to chronic situations, we do arthrograms more than other people.
Yeah, thank you very much. So I think the question again from Dr. Ken Shea from Singapore, who already asked about the bicep cooling lesions, and he asked that the question: any role of ultrasound in sport injury in this situation?
Any role of, sorry, beg your pardon?
Ultrasound.
Ultrasound. Oh yes.
Yep.
So I have a portable ultrasound with me all the time. It travels with me. It's a GEV scanner is what I do. And we also have ultrasound in all our locker rooms as such. I run on the sidelines and I travel with them as well and go to different places. And there is a role for it. The classic ones are ones with large injuries. The reason why you're talking about hyperacute ultrasound, which is like right there on the field. When do we do that? So once we do that, are all lower extremity injuries, we do them straight away. I look at them, all of them. The reason is I want to know, is it a high-grade tear, particularly Achilles? If there's any injury, those things are very important. High-grade muscle injuries, because I showed you a couple of pictures of football. These guys are huge, and we don't want them to progress. That's another thing we do. Rotator cuff, I only look for massive injuries. I'm not looking for anything major. Other finger injuries and stuff like that, in the sports that I deal with, basketball and in football, we tend to tape these guys and we don't ultrasound those ones very quickly. Knee, we're just looking for joint effusion. But one little story, the time that I saved somebody was, there was a guy who had a helmet to his belly and they took him to the locker room. They say, we got to wait on him. But I said, let me take a look. And I found a bleeding spleen. So he got a spleen out. And that was one situation where it was really life-saving, where I did a focused ultrasound. So there is a role, but hopefully that's very rare. And so that's when we do it. Other than that, we do a lot of ultrasound in the subacute phase. Yes, there is a huge role for ultrasound in sports in the subacute phase.
Thank you. I think is that everything clear for the audience? Any further questions? So I think if anyone have a question, you should send the email in the, I think the email in the address in the email sent to you. And I think Professor Kumar will very happy to answer the question. And
absolutely,
I think now I'll give the microphone back to the organizer of the talk. And please.
Thank you so much, Dr. Trong, for moderating this session. Really appreciate that. And Dr. Nix, thank you so much for such a wonderful, well-illustrated session here. I mean, you almost swayed me to stop my cardiothoracic and do MSK.
You're very generous. And it's easy. That's all I can tell you. It's very easy.
And those, especially those correlation with the MR and those videos were great. I mean, very, very. I have a slap tear now. I know. I think it's possibly type 1, and you said probably like 40-45. So that's where I stand right now.
Everybody's got one at that point, and I'm sorry that you have one. I hope you feel better.
Thank you so much. So again, Dr. Rong, thank you so much for moderating this. Sorry, we got a little technical problem initially with you joining us, but this is great session. So we'll have a quiz right now. I mean, for all the attendees, just a small question to encourage them. and we give like 2 minutes for them to answer. So can we have the quiz, please? Nat, do you have anything before that?
No, I don't. Please go ahead.
Yeah, thank you.
And I just wanted to say thank you guys, and thanks very much, JP and Nat, for and Dr. Wen for actually being allowing me to do this, and thanks for letting us share what we know. I appreciate
Thank
it
you very much
completely. Thank you.
indeed, and thank you for sharing your experience.
Thank you again.
Thank
Thank
you,
you.
sir. Thank you. IT team, can we have who is shared on the screen, please? Thank you. All right, guys, I mean, after this session, great session from Dr. Nix, I mean, this should be a cakewalk for you guys. This is a history of trauma. What is the diagnosis? You see a T2 weighted fat-SAT image where I also have an arrow on that, and a PDW image there, proton density weighted images. So what is the diagnosis on these MR of the shoulder? As this option A, supraspinatus tear, option B, biceps tendinosis, C, shoulder impingement, D, subcapsular tendinitis. So you have 2 minutes, and please make sure you scan the QR code which is shown on this slide and then answer. Please do not post your answers on the Q&A box or on the chat box. Please use your cell phone or use your electronic device and scan the QR code and then answer the question. History of trauma, what is the diagnosis? Option A, supraspinatus tear. Option B, biceps tendinosis. Option C, shoulder impingement. And option D is subscapular tendinitis. You have 90 more seconds. Last 60 seconds. What is the diagnosis of this? Please scan the QR code and answer your questions, please. Last 30 seconds. Last 15. All right, great. I think you got enough time to answer this question. Can we go to the answer, please? Great. So this was answer A. This was a supraspinatus tear. You could see that there was an incomplete, small, full thickness tear where you see the arrow of the distal supraspinatus tendon with no evidence of retraction. So this was option A is the right answer. Great. Thank you so much for doing this. And we have, can we get the next slide to look at the QR code for a feedback for evaluation? Please use the QR code for evaluating this session. And the certificates would be issued only for those who complete the evaluation. So please take time. It takes less than 5 minutes to fill this evaluation form. Please do that. And also, please don't forget to log back in on September 1st. That's 2 weeks from now. That's Sunday. We have our last MSK session on imaging in low back pain, and that is being delivered by Dr. Octavia. He's a neuroradiologist from University of Louisiana in Shreveport. So that would be imaging in low back pain. So again, once again, thank you all the attendees for attending this great session. Thank you so much. Thanks for all the panelists. Thanks for the moderator and speaker. Thanks everyone for, and mainly thank you for the IT committee, all the committees in the background who made this work possible. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.